All right, welcome to our OCS Hip Masterclass. Now, if you're gearing up for the exam, you already know that non-arthritic hip pain, man, it can be a really tricky area, right? So in this session, we're going to cut right through all the noise. We're going to focus on what the evidence actually says, the most effective interventions you need to know. Let's dive in.
Okay, let's kick things off with a scenario that I bet is super familiar to every single one of you. You've got this runner. They come in with that classic lateral hip pain. We've all seen this patient, right? So I want you to just kind of tuck this case away in the back of your mind because by the time we're done here, you're going to have a rock-solid, evidence-based framework to nail this diagnosis and treatment with total confidence.
So here's the game plan for today. First, we're going to talk about the why, the whole philosophy behind an impairment-based approach. Then, we'll start building out our intervention toolbox. After that, we'll get laser-focused on strengthening, apply all this stuff to specific conditions, and then we're going to put your skills to the test with a case challenge. And of course, we'll wrap it all up with the 5 core takeaways you can start using in the clinic tomorrow.
All right, first things first, we have to establish our core philosophy here. Look, to really crush it, especially on a test like the OCS, you've got to think beyond just slapping a diagnostic label on someone. We have to operate from a true impairment-based framework. This is foundational.
And here's the big mental shift we need to make. Labels like greater trochanteric pain syndrome or piriformis syndrome, they're useful, for sure, they help us communicate, but they don't really tell us what to treat, do they? The real magic, the OCS level thinking, happens when we look deeper. We start looking at the shared functional problems, the weakness, the poor motor control, the mobility issues. Your job as the expert in the room is to find those impairments and target them. That right there is where clinical precision comes from.
Okay, so we've got our philosophy locked in. Now let's start filling up that intervention toolbox. We're going to systematically go through the evidence for all the stuff we use day in and day out. Manual therapy, flexibility, the whole shebang.
So when we're talking about manual therapy for the hip, you've got to start where the evidence is the absolute strongest. And where do we find that? Well, we go straight to the source, the clinical practice guidelines, the CPGs. This isn't just nice-to-know info. This is non-negotiable, 100% testable stuff.
And what's really striking here is just how strong this recommendation is. It's not wishy-washy at all. The 2017 HIP OA CPG gives a grade A. That's strong evidence, folks, supporting manual therapy. And it's not just talking about one specific technique either. This covers thrust, non-thrust, and soft tissue work for anyone with mild to moderate HIP OA. This is absolutely a foundational piece of evidence you have to know cold.
But here's the thing, the CBG doesn't just say do manual therapy, it gets specific. It gives us an evidence-based dosage. And the first part of that prescription, it's the frequency. We're looking at 1 to 3 times per week.
And the second part of that prescription is the duration, 6 to 12 weeks. So let's put that all together. The full evidence-based dose is 1 to 3 times per week for 6 to 12 weeks. These are exactly the kind of specific numbers that you need to have locked and loaded for your exam.
Now, this next point is a really critical distinction, so pay close attention. For HIP OA, the evidence for manual therapy is rock solid, right? Grade A. But for non-arthritic hip pain, it's a completely different story. The CPG recommendation there is based on expert opinion. Now, does that mean we just throw it out? No, of course not. It just means the evidence isn't as strong, and that's where your clinical reasoning has to be razor sharp. This is a super important nuance.
And of course, we always have to talk about contraindications. When we're thinking about joint mobs specifically, you've got to be screening for things like joint hypermobility or known hip dysplasia. And a huge one, if your technique starts to peripheralize their symptoms, you stop, period. Safety and precision, they always come first.
All right, what about dry needling? Well, there was a great systematic review back in 2017 by Gaddy and his team. And what they found was, yeah, it can be effective for short-term pain relief. We're talking less than 12 weeks. But here's the really important part to remember. The evidence for any long-term benefit just isn't there yet. So what does that mean for us? It means it's a fantastic tool to modulate pain, to open up a window of opportunity so you can get them moving and doing their exercises, but it is not a standalone long-term solution.
Okay, let's talk flexibility. This is a cornerstone of what we do, but it has to be impairment-driven. We can't just hand out a generic hamstring stretch to everyone. You have to ask yourself, are their adductors actually tight? Is it the rectus femoris that's the problem? You have to prescribe based on what you find on your exam. And obviously, we've got to be cautious.
You got a patient with FAI? We're staying away from those combined flexion, adduction, and internal rotation positions. And if they're hypermobile or have dysplasia, aggressive stretching is a big no-go.
All right, let's move on to our next section, and this one is absolutely critical. We're talking about targeted strengthening. Look, we've all prescribed a clamshell, right? But OCS-level practice, it demands that we go way beyond that. We have to understand the why and the how behind our exercise selection with total precision.
So here is the classic clinical question, right? Your main goal is to strengthen the hip abductors. You want to beef up that glute med to get better control in the frontal plane. But what do we see all the time? Patients just totally overusing their TFL, the tensor fasciae lati. So the million-dollar question is, how do we pick exercises that really fire up the glute medius while telling the TFL to just chill out?
Well, lucky for us, we have some really strong evidence to guide us here. There's a landmark EMG study by Selkowitz from 2013 that did the work for us. They identified the top 3 exercises for getting the highest glute to TFL activation ratio. So, what are they? Number 1 is the resisted clamshell. After that, we've got the side step with a band, specifically above the knees. And number 3 is the unilateral bridge. Knowing this list is a game changer. It lets us move away from just guessing and straight into evidence-based prescription.
Now the glute max, that's a different beast. It presents a really unique challenge because it has a surprisingly small representation in the brain's motor cortex. It can be just plain hard to activate. But a 2016 study by Fisher and his team gave us a really clever solution. You got to prime the system first. They found that doing an isometric hold in the fire hydrant position, that's quadruped hip extension, abduction, and external rotation, it actually improves corticomotor excitability. It wakes up the connection from the brain to the muscle. So this is an awesome technique to use before your main strengthening stuff to really get that muscle firing.
And one last super important point here. We cannot treat the hip in a bubble. It just doesn't work. A strong, stable lumbopelvic region is the absolute foundation for everything the hip does. So addressing core strength and endurance, that shouldn't be an afterthought. It has to be a standard, non-negotiable part of any hip rehab program, period.
Okay, so our toolbox is getting pretty full. We've got our principles, we've got our interventions. Now, let's see how it all comes together. Let's start applying this to the specific conditions you're going to see in the clinic.
Remember that runner from the beginning, the one with lateral hip pain, likely GTPS? Let's circle back to him. The evidence points to a 3-pronged attack. First, strengthening. We're zeroing in on those hip abductors to get control of that frontal plane. Second, smart load management. You can use isometrics in the really acute phase because they have a nice pain-relieving effect. Then you logically progress from non-weight bearing up to weight bearing. And third, motor control. The big goal here is to stop that excessive hip adduction when they're moving. A really beautiful progression for this is to go from a double leg squat to single leg balance and then finally to a single leg squat. And you're just hammering that pelvic stability cue the whole time.
All right, next up, piriformis syndrome. As soon as you see this diagnosis, 2 main goals should pop right in your head. Goal number 1, calm down that irritated piriformis muscle. Goal number 2, if the sciatic nerve is involved, we've got to decrease any compression on it.
So how do we do that? Well, first off, education is huge. Simple things like telling them to stop crossing their legs or to take that wallet out of their back pocket. It can make a massive difference. Second, if you decide stretching is the right move, you have to be precise. A study by Gullidge found the optimal position to stretch the piriformis. Get ready for these numbers, they're important. 115 to 120 degrees of flexion, 40 to 50 degrees of external rotation, and 25 to 30 degrees of adduction. Lock those numbers in. Third, you've got to address the why. And often, that's glute weakness making the piriformis work overtime as an abductor. And finally, yeah, you can use soft tissue work, but you got to be careful. If it makes things worse or sends symptoms down the leg, you stop right away.
Next, let's touch on a condition that's maybe a little less common but still really important to know about: ischiofemoral impingement, or IFI. Now, the most vital thing for you to understand about IFI is that the high-level research for rehab, it's just not there yet. It's still emerging. So what does that mean? It means our treatment has to be 100% anchored in that solid, impairment-based clinical reasoning we talked about earlier.
And this quote right here, it perfectly highlights that evidence gap. I mean, it's totally explicit. Right now, there is no specific research to support using soft tissue work or dry needling for IFI. That is a critical point. As an expert clinician, knowing where the evidence stops is just as important as knowing the guidelines themselves. So without that diagnosis-specific evidence, what do? We fall back on our fundamental principles.
We build a logical progression based on the patient-specific impairments. So number 1, you address mobility, anything that might be closing down that ischiofemoral space. Maybe that's a medial inferior joint mob to improve abduction, or maybe it's stretching tight adductors. Number 2, you strengthen for stability. You're prioritizing those hip abductors and external rotators to control the pelvis. And number 3, you retrain motor control, progressing them through functional activities that make sense for them.
All right, it's go time. Time to put all of this together. You have the knowledge. Now let's see if you can apply it. We're going to walk through a case here to really challenge your clinical reasoning.
Okay, here's the scenario. You've got a 32-year-old guy, he's complaining of this deep buttock pain, and it even refers a bit down his posterior thigh. He tells you it's worse when he sits for a long time and when he crosses his legs. On your exam, you get a positive FAIR test, and you find clear weakness in both hip abduction and extension. So, get those wheels turning. What's your hypothesis?
So based on that whole clinical picture, what's your first move? What intervention are you going to prioritize right out of the gate? Are you going with A, an aggressive piriformis stretch, B, strengthening the glute max and medius, or C, a long-axis hip distraction? Think it through for a second. What's the best first step?
The best answer here is B, glute max and medius strengthening. So why is that? Well, the whole cluster of findings, it's screaming piriformis syndrome, right? But it's most likely secondary to that gluteal weakness you found. That's the real driver of the problem. So why not A? Well, aggressive stretching is a bad idea here, especially with that tissue irritability and the nerve referral. And C? Sure, a long axis stretching might feel good, it could be a helpful adjunct, but it doesn't get to the root of the problem, which is a muscle performance deficit.
Okay, quick retrieval practice. Time to pull that information back out of your brain. No multiple choice this time. Tell me the specific evidence-based dosage for manual therapy for a patient with mild hip OA. I need frequency and duration, straight from the CPG. What is it?
And the answer is 1 to 3 times per week for 6 to 12 weeks. That's based on that strong, grade A evidence from the 2017 AOPT CPG. I hope that one was right on the tip of your tongue.
Wow. Okay, we have covered a ton of ground. So let's boil all of this down. What are the absolute most essential, high-yield takeaways? The things you need to lock in, not just for the exam, but for your practice every single day.
Look, I know that was a lot of information, but if you only remember 5 things from this whole masterclass, make it these 5. Number 1, treat the impairment, not just the label. That's huge. Number 2, dose your manual therapy with precision. Remember those numbers for hip OA, 1 to 3 times a week for 6 to 12 weeks. Number 3, target the glutes intelligently. Use those specific exercises to bias the glutes over the TFL. Number 4, stretch the piriformis the right way using those specific joint angles we talked about. And last, number 5, acknowledge the gaps in the evidence. For things like FI, you've got to rely on your sound impairment-based clinical reasoning.
So let's end on this note. The whole point of learning all this stuff is to actually apply it, right? So take just a second and really think about it. What is one specific thing you learned today that you are going to use to change, to refine your treatment the very next time a patient with hip pain walks into your clinic? Because that is how we turn knowledge into true expertise. Thanks so much for joining me.